Good evening, Dr. Phil here. Today we will be discussing on popliteal sciatic nerve block. Anatomy. Boundaries of the popliteal fossa. Superior medially the semitendinosus, superior laterally the biceps femoris, inferior medially the medial head of the gastrocnemius, inferior laterally the lateral head of the gastrocnemius. Contents of the popliteal fossa: popliteal artery, popliteal vein, and sciatic nerve, which consists of the common peroneal nerve and the tibial nerve. In the popliteal fossa, superiorly, the sciatic nerve is immediately superficial to the adductor magnus. Inferiorly, the sciatic nerve is superficial to the femur. Indications for popliteal block: for anesthesia for surgery below the knee level, in combination with a saphenous or femoral nerve block. For example, corrective foot surgery, foot debridement, short saphenous vein stripping, repair of Achilles tendon, etc. Analgesia for surgery or pain occurring below the knee level, in combination with a saphenous or femoral nerve block. The popliteal sciatic nerve block anesthetizes the leg distal to the hamstring muscles. Patients are thus able to perform knee flexion. Complications: infection, strip A sepsis is a must. Hematoma, to reduce risk of hematoma, avoid multiple needle passes, large needle diameter, and Tohi needles if possible. Local anesthetic toxicity, avoid exceeding the maximum dose, avoid intravascular injection, frequent aspiration prior to LA injection should be done. Vascular puncture, to reduce risk of vascular puncture, avoid deep needle insertion. The vascular sheath is medial and deep to the sciatic nerve. Withdraw the needle and redirect at a different angle and do not advance deeper if the sciatic nerve is not localized within 2 cm after the local twitches of biceps stop. Nerve injury. Avoid multiple needle passes. Do not inject LA when stimulation is obtained at less than 0.2 mA, 0.1 seconds, opening injection pressure more than 15 psi, or when the patient complains of severe pain. Short bevel needles should be used. Use ultrasound guidance whenever possible. Pressure necrosis of the heel. To avoid this, use heel padding, frequent repositioning, and meticulous care of the insensate extremity. LA choices: 3% 2-chloroprocaine, onset 10 to 15 minutes, anesthesia 1 hour, analgesia lasts for 2 hours. 1.5% mepivacaine, onset 15 to 20 minutes, anesthesia 2 to 3 hours, analgesia 3 to 5 hours. 1.5% mepivacaine plus adrenaline, onset 15 to 20 minutes, anesthesia 2 to 5 hours, analgesia 3 to 8 hours. 2% lidocaine plus adrenaline, onset 10 to 20 minutes, anesthesia 2 to 5 hours, analgesia 3 to 8 hours. 0.5% ropivacaine, onset 15 to 30 minutes, anesthesia 4 to 8 hours, analgesia 5 to 12 hours. 0.75% ropivacaine, onset 10 to 15 minutes, anesthesia 5 to 10 hours, analgesia 6 to 24 hours. 0.5% levobupivacaine, onset 15 to 30 minutes, anesthesia 5 to 15 hours, analgesia 6 to 30 hours. Peripheral nerve stimulator technique, posterior approach. Introduction. This is the first described popliteal block and can be performed with the patient in various positions, including prone, lateral, and supine. In supine position, the leg needs to be held with the hip and knee flexed to 90 degrees by an assistant. This approach is more likely to block the sciatic nerve prior to its bifurcation, as it is a more proximal approach than the lateral approach. Onset time of block is 20 to 30 minutes. Important landmarks includes the semimembranosus, biceps femoris, and popliteal crease. Technique. General measures kindly refer to the video on peripheral nerve stimulation in peripheral nerve blocks. Needle insertion point: identify the isosceles triangle formed by the semimembranosus and biceps femoris, both of which forms the apex, and the popliteal crease, which forms the base of the triangle. To accentuate these landmarks, flex the knee against resistance. Draw a line connecting the apex to the middle of the popliteal crease. The needle insertion point is 5 to 8 cm cranial from the base of this triangle, 1 cm lateral to the midline, 1 cm lateral to the palpable pulse of the popliteal artery. Needle direction is 45 to 60 degrees to the skin in a cranial direction. Needle depth. Advance needle until a motor response is elicited, or needle depth is more than the radius of the leg. Motor response is usually elicited at 3 to 8 cm needle depth. Standard aseptic measures. Anesthetize the skin with subcutaneous lidocaine. Needle of choice is 50 mm 21 gauge insulated short bevel stimulating needle. Nerve stimulator attached to the needle. 1.5 mA 0.1 milliseconds, 2 Hz pulses. Desired motor response upon needle advancement. Peroneal nerve stimulation results in dorsiflexion or eversion of the foot. The peroneal nerve lies laterally in the sciatic bundle. The tibial nerve lies medially in the sciatic bundle. Stimulation of the tibial nerve results in plantar flexion of the foot or toes. Tibial nerve stimulation results in higher success rates in sciatic nerve block in single injection techniques. If no motor response, withdraw and redirect sequentially in 5-degree angles laterally then medially. If bone is encountered, withdraw and redirect sequentially in 5-degree angles laterally and then medially. Double injection technique do not improve nerve block success rates. LA injection. Manipulate the needle until the desired motor response is seen at a stimulating current of between 0.3 and 0.5 mA. Disconnect the syringe prior to LA injection to exclude passive reflux of blood. If no blood on aspiration, inject LA in 5 mL aliquots to 10 to 15 mL for each component. Aspirate regularly to exclude intravascular injection. The block duration is increased more by volume rather than concentration of LA and is influenced by the type of LA as discussed earlier. The block duration is prolonged by addition of clonidine or adrenaline. Troubleshooting. Response observed. Local twitch of biceps femoris. Interpretation. Direct stimulation of biceps femoris. Issue. Needle placement is too lateral. Correction. Withdraw the needle and redirect slightly medially 5 to 10 degrees. Response observed. Local twitch of semitendinosus or semimembranosus. Interpretation. Direct stimulation of the above-mentioned muscles. Issue. Needle is placed too medial. Correction. Withdraw the needle and reinsert slightly laterally 5 to 10 degrees. Response observed. Calf muscles twitches without foot or toe movement. Interpretation. Muscular branches of the sciatic nerve are stimulated. Issue. These branches are often outside the sciatic sheath. Correction. Advance the needle further until foot and toe twitches are obtained. Response observed. Blood aspirated in the syringe. Interpretation. Popliteal artery or vein puncture. Issue. Needle placement is too deep or too medial. Correction. Withdraw the needle and redirect laterally. Response observed. Bone contact. Interpretation. Needle encounters femur. Issue. Needle placement is too deep. Correction. Withdraw the needle slowly. Look for foot twitch. If no twitches, reinsert in another direction. Popliteal nerve stimulator technique, lateral approach. Advantages. This can be performed with the patient in supine position who are unable to adopt other positions due to conditions such as painful fractures. Disadvantages. This approach takes longer to perform than a posterior approach. Block onset 20 to 30 minutes. Landmarks includes the lateral groove between the vastus lateralis and long head of the biceps femoris and the patella. Technique. General measures kindly refer to the video on peripheral nerve stimulation in peripheral nerve blocks. Patient position is supine with the leg slightly flexed. Needle insertion point. Identify the lateral groove. Tense up the ventral and dorsal thigh muscles against resistance to make this groove more prominent. The groove is in line with a line extended from the lateral margin of the fibula when the knee is fully extended. Identify the superior border of the patella. Mark a point of intersection between the lateral groove and a line dropped from the superior border of the patella. Needle direction is 30 degrees posteriorly and 5 to 10 degrees caudally. Needle depth. Advance needle until a motor response is elicited or needle depth is more than the radius of the leg. Use standard aseptic measures Anesthetize the skin with subcutaneous lidocaine. Needle of choice is 50 mm 21 gauge insulated short bevel stimulating needle. Nerve stimulator attached to the needle, set at 1.5 mA, 0.1 milliseconds at 2 Hz pulses. Desired motor response upon needle advancement. Peroneal nerve is often stimulated first, as it lies laterally in the sciatic bundle. There will be dorsiflexion or eversion of the foot. Stimulation often occurs within 10 to 20 mm of the skin. The tibial nerve lies medially in the sciatic bundle. Plantar flexion of the foot or toes occurs with tibial nerve stimulation. Stimulation often occurs within 30 to 50 mm of the skin. Tibial nerve stimulation results in higher success rates in sciatic nerve block in single injection techniques. If no motor response, redirect the needle in 5 degrees increment along an anterior-posterior line. Popliteal vascular injection is more likely with increasing anterior angulation. The nerve is often superficial rather than deeply situated. If direct muscle stimulation is elicited, ensure needle puncture site is between vastus lateralis and biceps femoris. Double injection technique. Motor response of both peroneal and tibial nerves are sought. Double injection technique has higher success rates than single injection techniques, 88 versus 54%. Inject LA as mentioned in the posterior approach when the desired motor response is obtained. The block duration is increased more by volume rather than concentration of LA, influenced by the type of LA as discussed earlier, and prolonged by addition of clonidine or adrenaline. Troubleshooting. Response observed, local twitch of biceps femoris. Interpretation, direct stimulation of biceps femoris. Issue, needle placement is too shallow. Correction, advance the needle deeper. Response observed, local twitch of vastus lateralis. Interpretation, direct stimulation of the vastus lateralis. Needle placement is too anterior. Correction, withdraw the needle and reinsert posteriorly. Response observed, calf muscles twitches without foot or toe movement. Interpretation, muscular branches of the sciatic nerve are stimulated. Issue, these branches are often outside of the sciatic sheath. Correction, advance the needle further until foot or toe twitches are obtained. Response observed, blood aspirated in syringe. Interpretation, popliteal artery or vein puncture. Issue, needle placement is too deep or too anterior. Correction, withdraw the needle and redirect laterally. Response observed, twitches of foot or toe. Interpretation, sciatic nerve stimulated. Correct needle placement, inject LA as required. Popliteal sciatic nerve block ultrasound technique. Advantages of ultrasound over peripheral nerve stimulation technique for popliteal sciatic nerve blocks. It is less time consuming, requires less needle passes, it is less affected by anatomical variations, there is improved patient comfort, enhanced quality of nerve block, faster onset of nerve block, less complications. Ultrasound techniques avoid the need for muscle group contraction, which is useful in certain patient groups, such as in trauma patients, where muscle contraction will cause severe pain. It is also useful in patients with impaired response to nerve stimulators, such as patients with diabetes and peripheral vascular disease. Preliminary scan. Although it is difficult, it is possible to visualize the sciatic nerve throughout its length, from its subgluteal location to the popliteal fossa, where it bifurcates, where the best images are reported to be 7 to 11 cm distal to the gluteal crease. Refer to proximal sciatic nerve block for further details. Patient position can be prone, supine or lateral. In the supine position, the knee is flexed at 90 degrees, the heel supported up by an assistant on the bed or raised up on a pillow. The probe position is transverse at the posterior aspect of the thigh at the level of the popliteal crease. Ultrasound setting, use a high-frequency linear probe, set at MB resolution, general, depth 3 to 6 cm. Identify structures. Identify the popliteal artery and vein. Doppler color flow is useful. The sciatic nerve lies between the semimembranosus medially and long head of biceps femoris laterally. The nerves are difficult to visualize as they have similar echogenicity to the surrounding muscle and are anisotropic. To help improve the visibility of the nerves, use the seesaw sign On dorsiflexion and plantarflexion of the foot, the resulting rotational movement of the nerves enhances their visibility. Tilt the probe and angle it distally will also help improve the visibility of the nerves. The tibial nerve is a hyperechoic oval structure superficial and medial to the popliteal artery. The common peroneal nerve is seen as a smaller hyperechoic oval structure superficial and lateral to the popliteal artery. The sural-communicating nerve branches off from the peroneal nerve as it descends towards the head of the fibula. The sciatic nerve is seen proximally where the tibial and common peroneal nerve starts to converge. Needle choice 50 to 100 mm of choice. Technique: use standard aseptic measures and anesthetize the skin with subcutaneous lidocaine. The sciatic nerve can either be blocked as a single injection technique or double injection technique after its bifurcation by blocking each of its components. Beware of missing the sural-communicating nerve. The in-plane approach in supine position or out-of-plane approach in prone position can be used. Peripheral nerve stimulation helps in nerve identification, especially in cases with difficult anatomy. Aim to surround the nerve with 10 to 20 mL of LA after negative aspiration. These are my references. Thank you.